Real-life medical detective story. We're going to explore the incredibly complex sensation of breathlessness. And we'll discover why that terrifying wheeze or tight chest you might be feeling, well, it might not actually be the classic asthma you think it is. We're going on a journey through diagnostic clues, physiological mimics, and the absolute latest 2024 medical guidelines. All of this is designed to help us unmask the real culprits behind why we sometimes struggle to breathe. So let's get into it.
Okay, let's set up our crime scene. Imagine you're struggling to breathe. Your chest feels incredibly tight, and maybe you're even wheezing. For decades, the immediate assumption for almost everyone has been, oh, it's bronchial asthma. But here's the thing. Breathlessness is super subjective. It's often described as chest tightness, suffocation, or this deep air hunger. And as primary care data clearly shows us, before we jump straight to the conclusion of asthma, we actually have to investigate a whole lineup of stealthy medical imposters. Our bodies are just wonderfully complex, and several entirely different systems can trigger those exact same terrifying symptoms.
So, let's look at this breakdown of diagnostic clues straight from primary care. It turns out specific variations of breathlessness point us toward completely different culprits. For instance, if that breathlessness hits you incredibly suddenly, boom, that's a major red flag for a pulmonary embolism or a pneumothorax. On the other hand, if you experience orthopnea, which is basically breathlessness that gets much worse when you lie down, well, that points the finger firmly at heart failure, not your lungs. And if you've got pleuritic chest pain alongside it, that sharp stabbing pain right when you breathe in, we might actually be looking at pericarditis. It's really only when we see a history of waking up in the night or breathlessness during exercise that classic asthma or COPD truly become our prime suspects.
Which leads us right to our very first major imposter. And honestly, it's a condition that sounds completely paradoxical. Cardiac asthma. It's this fascinating, kind of deceptive condition where a failing heart perfectly masquerades as a lung problem. I mean, patients show up with wheezing, shortness of breath, coughing, chest tightness, literally the exact profile of bronchial asthma. But the plot twist? The root cause isn't chronic inflammation of the airways at all. It's actually congestive heart failure.
To really understand this, we have to look at the true origin of the problem. It starts when the left side of the heart starts to fail and just can't pump blood effectively anymore. What happens next? That pressure in the pulmonary circulation shoots up. And that elevated pressure essentially forces fluid to accumulate right in the lungs. It's this fluid buildup, what doctors call pulmonary congestion, that physically constricts the airways. That's what leads to the wheezing and breathlessness. So in reality, the lungs are basically the victims of a failing heart.
So, how do we catch this particular suspect? Well, medical detectives can't just look at lung function. They absolutely need specific forensic clues. First off, they dig into the patient's history looking for hypertension or coronary artery disease. Then, they run blood tests for BNP. Now, BNP is a hormone released by the heart when it's under stress, so an elevated level is a massive clue. On top of that, chest x-rays can reveal an enlarged cardiac silhouette and these highly specific fluid patterns called curly B lines. Finally, they'll use an echocardiogram to check out the heart's actual pumping function. Because honestly, only by looking directly at the heart can we rule out this sneaky asthma imposter.
Right, this brings us to suspect number 2. This is a condition frequently seen in adolescent females, and it perfectly mimics exercise-induced asthma. It's called vocal cord dysfunction, or VCD. In VCD, the vocal cords, which are absolutely supposed to open wide when we breathe in, they involuntarily snap shut instead. This functional obstruction happens right there in the throat, but to the patient, it feels like a terrifying inability to get any air into the lungs. And sadly, this often leads to repeated, totally unnecessary emergency room visits and asthma treatments that just don't work.
So the absolutely crucial point here is comparing these two directly. VCD causes a struggle breathing in, an inspiratory struggle, and that wheezing sound usually originates higher up, right in the neck or throat. But the biggest giveaway? VCD symptoms typically peak right smack in the middle of exercise. On the flip side, classic asthma is characterized by an expiratory struggle, a struggle breathing out that originates much deeper in the chest. And with asthma, those symptoms usually hit their peak about 5 to 20 minutes after you actually stop exercising.
But here's the really tricky part. VCD symptoms vanish super quickly once you rest. If a doctor checks the patient an hour later, everything looks totally normal. No way to catch it. Because of this, doctors use something called the continuous laryngoscopy exercise, or a CLE test. They literally attach a fiber optic laryngoscope and a tiny camera to a patient while they're actually running on a treadmill or riding a stationary bike. This setup allows them to catch the vocal cords right in the very act of involuntary closure during exercise, definitively proving that the obstruction is in the throat, not the lungs. It's pretty amazing.
Section 2. Catching True Bronchial Asthma. The 2024 BTS, NICE, and SIGN guidelines. Let's get into it.
After ruling out all those red herrings, we turn to the latest medical standards to officially confirm true bronchial asthma. And today, that requires hard, objective tests. The first major one checks for fractional exhaled nitric oxide, or FeNO. Now, nitric oxide is just a gas produced by the lungs whenever there's allergic inflammation. For adults, if you have a FeNO level of 50 parts per billion or more, that is a definitive, objective marker to confirm an asthma diagnosis. It's a simple breath test, but it leaves zero room for guesswork.
But things shift slightly for younger patients. The 2024 guidelines specify that for kids and teens aged 5 to 16, their bodies naturally produce different baseline levels. Because of that, they actually require a lower FeNO threshold. For them, a reading of just 35 parts per billion or more is enough to confirm the diagnosis.
Now, what if those FeNO levels aren't raised, or maybe the test just isn't available? Well, the next forensic tool in the kit is bronchodilator reversibility, using spirometry. This basically tests how much air you can forcefully blow out in exactly 1 second, something called FEV1. Doctors measure this, hand you an asthma inhaler, wait a bit, and then measure it again. In adults, we're looking for a 12% and a 200 milliliter increase in that FEV1 to prove the airways are actually reactive. In kids, just a 12% increase from their baseline is totally sufficient to pin down that asthma culprit.
Sometimes though spirometry isn't immediately available either, or we just need a bit more data to be sure. In that case, we fall back to having the patient monitor their peak expiratory flow twice a day for 2 full weeks. The whole objective here is to look for variability. If your peak flow fluctuates by 20% or more over that 2-week window, well, that perfectly demonstrates the hallmark of variable airway obstruction of asthma, and that variability alone is enough to lock in the diagnosis.
Section 3. Managing the real culprit, the pharmacological treatment action plan.
All right, so once we've definitively identified asthma as the real culprit and we've totally ruled out those failing hearts and misbehaving vocal cords, the 2024 guidelines lay out a very specific, stepped action plan for newly diagnosed patients age 12 and over. Check this out. Step 1 is now as-needed AIR therapy. AIR stands for anti-inflammatory reliever. This basically means using a low-dose inhaled corticosteroid combined with formoterol, but only when symptoms actually hit. If that's not cutting it, we step things up to low-dose MART, which is maintenance and reliever therapy. Here, the patient takes the inhaler regularly every single day, plus extra doses if they need immediate relief. And if symptoms are still stubbornly persisting, we escalate to step 3, which is moderate dose MART. It's a really structured escalation designed to keep that airway inflammation firmly in check.
But what happens if those treatments just aren't working? Well, the guidelines are crystal clear here. Before we just throw higher doses of drugs at the patient, we absolutely have to investigate secondary factors. I mean, are they actually using the inhaler correctly? Are they smoking or vaping? Could they be exposed to harsh chemicals at work or maybe indoor mold at home? We also have to seriously consider psychosocial factors like anxiety and depression because those can severely impact how a person perceives their own breathlessness. Basically, we have to make sure the patient's environment or technique aren't accidentally sabotaging their medication.
Now here is a genuinely surprising fact from these new 2024 guidelines. Despite the massive explosion of medical technology and smart devices we've seen recently, digital smart inhalers are explicitly not recommended for routine use in asthma management. I know, right? While they might seem like a brilliant way to track if a patient is taking their meds, the current clinical evidence simply doesn't support using them as a standard tool for everyone. The medical focus remains heavily on teaching proper inhaler technique and having regular clinical reviews rather than just relying on digital tracking.
This entire medical mystery really reminds us that breathlessness is incredibly complex. Sure, it might be your lungs, but it could just as easily be your heart struggling under pressure, or your vocal cords just shutting out of absolutely nowhere. Listening closely to your body's specific signals, understanding the exact timing of your symptoms, and utilizing objective medical testing, that is the very first step to breathing easier. So I'll leave you with this to ponder. The next time you feel like you just can't catch your breath, will you actually know what your body is truly trying to tell you?